Okay, well, Janice was my counterpart. She was supposed to be here with me today, but she had a prior engagement, so it's just me. So I'm Angie. I'm a nurse with Encompass Health Rehab Hospital of Sarasota. A lot of people hear rehab and they think they're all the same, but we are we are quite different, and that's what I'm gonna explain here today. So a rehab hospital differs than most of the rehabs you see around here in that we are required to give a certain amount of therapy and the quality of therapy. So we are the only freestanding rehab hospital on this coast from Tampa to Miami. We are building one in Cape Coral and Naples, and those are in the works. And we actually have a new one that we built in Tampa. The rest of the acute rehabs are in hospitals, so they have wings. Like Fawcett has a 20-bed, Lee Memorial I think has 60 beds, and Sarasota Memorial has I want to say 50 beds. But this is all we do. We're not outpatient. We are not a nursing home. It is short, intensive rehab to get you home. So it says 96 beds, but we just opened 20 private beds, so that brings us to 50 private rooms and 66 companion rooms. But the companion rooms are large because a lot of therapy actually takes place in the room as well for some people. We do run pretty full, about 89% most of the time. We have 136 consulting physicians, so anytime you need specialized care, we can get that in there. Let's see. We are Joint Commission accredited, so we have 3 things that we had to get special certification in. That is in the care of an acute stroke patient. Actually, the American Heart Association recommends that anyone who's had an acute stroke comes to an acute rehab, not to a lower level skilled nursing rehab, because of the amount and quality of therapy you get with us. We also are accredited in spinal cord injuries and hip fractures. So let's see. Our most common conditions that we do see are neurological conditions: Parkinson's, multiple sclerosis, Guillain-Barré, many other types of peripheral neuropathies, brain injuries. Gosh, but those are where we shine, and we work in pods, meaning our therapists are in orthopods. We have stroke pods. We have neurological pods. So when a patient comes in with a certain type of diagnosis, they are with those therapists that specialize in that type of diagnosis. And they stay with that group of therapists so that they're not seeing someone new every single day while they're there. So let's see. So while they're there, they get 24-hour RN care, 24-hour respiratory care, should they need it. We have 4 attending physicians that are in and out every single day. And then we meet once a week with our whole team to discuss each patient's plan of care, how they're progressing, what they need at discharge. So it makes discharge planning way easier. The average length of stay for people, because of the amount of therapy they get with us a day, is only 13 days. The average stay at a nursing home rehab is about 30 days. So it's 13 versus 30. Our goal is always home. We know some people can't, but about 85% of our patients go home. The other 15 go to various places. Maybe we knew that they just needed a little more strengthening to go to the next level of rehab, but our goal is always home. And this was about the American stroke, that they recommend coming to an acute rehab. So other than respiratory care, we do hemo and peritoneal dialysis on site. They don't leave to go to that like other rehabs. We have our own pharmacy. We do IV antibiotics. We do TPN, which is IV nutrition, blood transfusions, PEG tube feedings. We have a full-time infection control nurse. Wound care nurse is full-time. We take life vests, which those are for your heart. Let's see, caregiver training, other things like that. We actually, I don't know if it's on this particular set of slides, but we also have what is called a second chance stroke program. So this is someone who's had a stroke in the past. They even could have had therapy, but say they got sick, maybe they ended up in the hospital, and now they've had a functional decline, and they've had weakness on the right side or something like that, and now that's exacerbated. They can come back to us for intensive therapy under our second chance stroke program and get some really good quality therapy as well. Let's see. These are just some of the equipment that we have. Vital Stem, that helps with strengthening the muscles in the neck, especially after a stroke or any type of with dysphagia, not being able to swallow, someone who coughs a lot when they eat. The auto ambulator was actually designed just for our hospital. It's designed for people who have not maybe walked or having difficulty walking. It helps create those neural pathways with actually making their body walk. It's a harness system, so it's pretty amazing. We have our own activities of daily living apartment. Looks like a real live apartment, and it shows it's the occupational therapist can take people in there to work on things like getting dressed, bathing, learning how to do things that once they leave the hospital, learning to do them safely, reducing the risk of falls, things like that. We have an 18,000 square foot gym where most of the therapy takes place. We actually have 2 other gyms that we opened up where we usually, they're smaller, so we keep our brain injury patients at those for less stimulus, because usually people with brain injuries tend to be distracted easier. Let's see, our community support groups that we offer. Our amputee support group is quite awesome. Our rehab liaison, Brenda, has taken them golfing, bowling. She takes them and does some pretty amazing things with them. We're really big with Parkinson's as well. We have stroke, MS. We stay pretty active with our patients once they leave. So these are some of the differences, like I said, between skilled nursing and who we are, acute rehab. And every level of care has its place. Skilled nursing has its place. Home health has its place. It's just, we're just a little bit higher level of care than a local skilled nursing rehab. So with that being said, our physicians, like I say, are in there every day. Physicians at a skilled nursing only have to be in there, I believe it's once every 30 days to see a patient. So it's quite different. We require 3 hours of therapy a day, 5 days a week for our patients. Speech is in addition to that 3 hours. At a local nursing home, you may get 1 hour because they're not reimbursed on rehab. They're reimbursed on nursing care. We are specializing in rehab, so that's why we offer so much on that end. These are just some of our outcomes. Our discharge to community rate, like I said, 81%. Discharged to a skilled nursing, 11% sometimes go there because they need that long-term care once they leave us. 6% go back to the hospital, which is a very low number. The average rate around here for other rehabs is anywhere from 18 to 25% of patients end up back in the hospital. So 6% for us is quite a feat. Let's see. So I didn't give a little bit of a summary. Encompass Health was called Health South for over 30 years prior to our rebranding a couple years ago. We're not just in the South anymore, so they opted to take on Encompass's name when they purchased them. And so our particular location is right up off of Bee Ridge on exit 207, literally right off the interstate. You can't miss it once you're off. But we have the ability, because we're a hospital, we can admit from home, we can admit from an assisted living, from another skilled nursing. We work with them quite well. From mostly hospitals is where we get our patients, but our 4th leading admission is our home program. So we can come out, see if they meet criteria. You just have to meet 2 criteria, and that's a medical need, meaning you have to have a condition that a physician would need to look over you while you're there, and then a functional need. And people, when I say functional need, many people have a different baseline. You could have a paraplegic that was able to transfer himself from his wheelchair to a bed, and now he's not able to do that. Well, that's his baseline. So our goals would be for him to be able to transfer himself again. So everybody's baseline on functionality is different. And that's what we do. We tailor the goals to the patient that we're seeing. So I'm very honored to work there. I've been there about 3.5 years, and I've had tons of family members come in and out of there, and they really do amazing work. The amount of people that come back, repeat customers that come back, especially with our Parkinson's program, because that is a progressively debilitating disease. So they come back once a year. They call it their tune-up, and they come back and get really good therapy for about 10, 12 days, and then they're good to go for a while. So that is it in a nutshell. I tried to keep it as simple and quick as possible. Let's see. Yeah, that's not my phone number, but you can call that one. That's the other guy's phone number. They got it mixed up, but I'm trying to think here if there was anything. Does anybody have any questions? You do? Oh, beautiful. That is one thing I did not touch on. Thank you. So, that is a good question. Absolutely. So, we take almost every insurance you can imagine. Now, Medicare is the easiest. So, with straight Medicare, we can get you in same day. You don't have to have any kind of therapy records prior to coming in. So, that's the easiest, Medicare. And we're covered just like a hospital. So, Medicare covers that first 80%, and if you have a secondary, they should pick up that other 20. Medicare Advantage plans, we work with all of the time. The only tricky thing with them is you have to have therapy notes within the last 48 hours. So that's saying if you're at home and you have home health and they're working with you, PT, OTs coming to your home to work with you, we just have to have notes within the last 48 hours from them to submit to your insurance company to say, hey, they've been working with therapy, it's not working, they need more intensive therapy to come in, and we make a case for them. And honestly, we have really good results. It can go, depends on the carrier, but usually 45 to 50%. It's tough, a little more tougher with the Medicare Advantage, but we do have good outcomes with them. We are in network with the VA. With VA, the patient has to initiate that with their primary care. We can't call the VA and ask for a referral. It has to come from the patient telling their doctor, hey, can you please make a referral to them? I need to go in. We work with workers' comp. Workers' comp is one of a big one as well. Anybody who's been hurt, very easy to work with workers' comp. They bring them in, no problem. Oh, yeah. Yes, absolutely. So I look at it like this. I also look at what was their what did they do prior to coming in? Were they active? Were they able to get around with their walker? Were they able to ambulate? If they've been down for a year prior to coming to us, we're probably not going to be able to do a whole lot with them in 13 days if they've already been down for a whole year prior. So this is someone who's had quite an acute event. You know, yeah, we've had, stroke, hip fracture, even if they've had a heart condition, like maybe they have a congestive heart failure and they've had a decline and they need management, come in for some therapy, manage their heart with their meds or whatever. Diabetes, you won't believe how many diabetics we get in there that have had issues with their, getting sick, UTIs, things like that. We have to bring them in, get their sugar under control, give them some therapy. You'd be surprised what we take, because 60%, I don't want to get too much into this, but 60% of the people that come in have to fall under what we call these CMS 13s. 13 diagnoses that we are required by the government to take 60%. The other 40% are our heart patients, our diabetes patients, our renal failure patients, things like that. And so we get a lot. And we are able to take more of those patients over the smaller rehabs because we have 116 beds. So we see a lot more of those patients than other local rehabs do. But yeah, we work really, really well with insurance companies. I think the only one we don't take is Freedom. And yeah, and I think, and we actually do work with Medicaid. We haven't in the past few months due to everything that's been going on. We've been trying to, but even Medicaid patients, we do take those, usually about one or two a month. Hip replacements, it depends. There's certain criteria. So if someone is over a certain age, they have a hip replacement, they qualify. I think it's 85, and they have a hip replacement, they qualify. Now, if you have a bilateral hip replacement, you automatically require you. Yeah, I know. Yeah, but an elective hip replacements, knee replacements, no. If it's a hip fracture that requires a replacement, yes. Yeah, they're very stringent. Correct. So that's why we can admit from home. You don't have to have a 3-day stay. You don't have to have any of that. You don't have to have a doctor's order. You can call and self-refer yourself or a friend and say, hey, this person needs therapy. Can you just see if they meet criteria? Yes. Yep. Yep. And they average. So that's an average. So we have people that have stayed 18, 19 days. Usually those are your real good neurological conditions that need a little extra time. So I always say this, 13 days is average. Now, if they are making progress and they've reached that 13 days, but yet they still think they can make a little bit more, they're not going to kick them out. They're going to give them what they need. That being said, if they've reached all their goals at 7 days, which happens all the time, especially with hip fractures, we're not going to make them stay either. So we would discharge them home. It's a long time. Correct. And it's because of the amount of therapy, and that's why I try to stress. Like I said, every level of care has its place, but when it comes to rehab, I really try to stress an IRF, which is what we are, IRF, inpatient rehab facility, compared to a SNF, a skilled nursing facility, is huge. It's 13 days. I always say this, 13 versus 30. You're with us on average of 13, or you're going to be at a SNF for about 30 days. So it's it's a significant amount of time when you're not with your loved one. So that much time. Yeah. Oh, yeah. And you can look online at Medicare.gov. You can look at all of our outcomes and see. It's pretty substantial what they do. Mm-hmm. 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 And that's what they do. They really try to start early on those. So if we get off for like 7 to 10 days, they're really trying early to say, okay, look, this is the progress they're making. We need a few more extra days. Can you give him or her? Yeah, they really have to fight. Mm-hmm. Mm-hmm. Do you at that 14 day? Is 14? 20? Oh, that's right. Yeah. Then they have to go. Yeah. Oh, that's good to know because they've always told us, oh, 30 days, 30 days. Oh, yeah. Medical complication. Yeah. No, it is good. I mean, like that, and that's why I said not everybody is a candidate for what we do. A lot of people can't handle the 3 hours of therapy. Yes, it's like boot camp. That's what we're called, but that's they say we're the boot camps of rehab. Not in a bad way. It's just the intensity and the amount of therapy you get. Some people can't. Some people they think they can get in there and do it, and they realize it's a lot. But it's the goal is to get them home. So that's our goal, and that's what we do. Yeah, it is required that they do. So here's the thing: if we know someone's low level, we take a lot of low level patients, okay, And if it's a low-level patient, we start them off on what we call a modified program. So we take that 15 hours, we divide it by 7, and it comes out to a little over 2 hours a day. So the 3 hours that we normally would give, it's broke up so much that they get a lot of rest breaks. It starts off in the morning by getting dressed, bathing, grooming, things like that. Then they get a break. Then they go for another session. Then they get a break. So it doesn't end until almost 3:34 in the afternoon. So even someone who needs a little bit more time, that 2 hours is broke up even more. But it's just to keep them moving and going. They're not sitting. We always tell people who want to visit their family members, we tell them, we're like, wait till the afternoon, because they are constantly going all day long. They're not sitting in that room in a wheelchair waiting around for someone to come get them. They're moving all the time. So that's why I said not everyone is a candidate for what we do. It's happened. They're like, okay, we're done. Send me somewhere else. I can't do this. And then they'll sometimes come back. They realize, but at the time, no, it's too much for them. So, but I think is that my time? Little time. No, but I think that's it. 151. We're efficient. We're efficient. I know, right? Oh, we do have visitation hours. We do. We do screen for COVID and all of that. Everyone's tested prior to coming in. If not, they're put in a private room by themselves until the rapid comes back, and we make sure that that's handled. And then we do take COVID recovered patients. We've had a lot of those that have gone through COVID and had a long, lengthy hospital stay and came to us from some really good intensive therapy. We have a lot of programs. We have the creative, arts and healing program that we do there with a lot of Parkinson's and stroke patients. You wouldn't believe how much art can help people in therapy. We have it hanging all over the hospital. So it really is, you walk in, it doesn't have a rehab feel. It literally feels like you're walking into a hospital. It's a gorgeous, if you ever get a chance to go up there, you can walk right in. They'll give you a tour. I always suggest that to the families. I'm like, don't call. Just walk right in. We have nothing to hide, I said. LVADs? Oh, outpatient. I thought you said LVADs. No outpatient. Strictly inpatient. Yeah. So Dr. De Jesus is our medical director. He's been with us for years. He's awesome. So, and we have a lot of physicians. Dr. Cameron. Most of our physicians are what they call physiatrists, meaning they're doctors of rehab medicine. So they have specialized accreditation in that. So I'm trying to fill in time. Yeah, no, they do. We have one of the lowest turnover rates in our therapy department because they love working there. I think for like I can't remember how many months it was. We had 0% turnover rate. It was almost a year. It felt like that nobody ever leaves. So it's a good place.